All right, good morning, everybody. Welcome to Pediatric Grand Rounds. Today I have the pleasure of introducing Dr. Kendra Francis, who's an acting assistant professor and a clinician researcher with the University of Washington School of Medicine and Seattle Children's in the Division of Gastroenterology and Hepatology. She completed her residency and fellowship with the University of Washington and Seattle Children's. As a pediatric gastroenterologist, her clinical expertise is in pediatric inflammatory bowel disease. Her current research focuses on the role of the intestinal barrier, specifically the extracellular matrix in chronic inflammatory diseases. So excited to have you today. Welcome, Dr. Francis. Thanks, everybody.
Thanks for that introduction, and thanks for inviting me to speak. I'm really excited to talk to you guys this morning. Like Dr. Mazur mentioned, I did all my training here, so I remember attending Grand Rounds as a medical student, a resident, and sometimes as a fellow too. So I understand the commitment it takes to come here. So I want to particularly thank the trainees for being here as well as the faculty and staff. So I'm a physician scientist. I research the extracellular matrix in inflammatory bowel disease, and I'm excited to talk to you about this topic today. I have no disclosures. So today I want to talk to you all about recognizing the increasing burden of pediatric IBD and some of the key features of different types of IBD. We will also discuss the factors involved in IBD pathogenesis. Then I will focus more on my own research and the knowledge gaps that it addresses by highlighting the role of the extracellular matrix in IBD pathogenesis. Then I'll show you the results of my research that detail important pathologic changes in the extracellular matrix in IBD. And at the end, I'll briefly touch on how these extracellular matrix changes can inform novel therapeutic targets in IBD. So let's talk about some definitions and basic characteristics of IBD first. IBD involves chronic autoimmune inflammation of the GI tract, and there is no known cure. There are two main types, ulcerative colitis and Crohn's disease. We do our best to fit our patients into one of these two categories, but in reality, the lines between them are a little bit more blurred than this depiction indicates. In terms of disease location, ulcerative colitis is aptly named because it involves the colon. It starts distally in the rectum, left side, and progresses to involve up to the entire colon, but the inflammation is always continuous. In contrast, Crohn's disease can involve any location of the bowel from mouth to anus, and the inflammation can be patchy with normal bowel interspersed between involved areas. In terms of the type of inflammation that's present, ulcerative colitis involves mucosal inflammation that doesn't penetrate beyond that mucosal layer of the colon. In contrast, Crohn's disease involves transmural inflammation that can penetrate beyond the intestinal wall and cause strictures and/or fistulae. Because of this, Crohn's disease can create perianal disease, and this is not seen in ulcerative colitis. Regarding the role of surgery, surgery can become a necessary part of the treatment plan for either type of IBD. In ulcerative colitis, a colectomy is theoretically curative, while a bowel resection in Crohn's disease is not felt to be fully curative. In terms of the signs and symptoms of IBD, they do differ by the disease type. Both UC and Crohn's can produce bloody diarrhea, but this is almost always present in UC. Most pediatricians don't think of IBD as causing constipation, but isolated small bowel Crohn's disease can indeed lead to constipation. Ultimately, the symptoms depend on the area of the bowel that's affected. This is why I love GI so much. We can always go back to the anatomy to answer many of our questions. So when the colon is affected, since it's more distal, any inflammation there tends to affect the stools more, cause diarrhea, urgency, rectal bleeding, frequency. Whereas in isolated small bowel Crohn's disease, it can cause more minimal symptoms and it can even lead to constipation. So a couple centimeters of proctitis or really distal ulcerative colitis can cause a lot more overt symptoms than a much more extensive involvement in small bowel Crohn's disease. Abdominal pain is generally a feature of both. Weight loss and growth failure tend to be more of a feature of Crohn's disease, particularly growth failure, but they can be seen in both. And then both diseases do cause extraintestinal manifestations, but they tend to be a bit more common in Crohn's disease. So extraintestinal manifestations like joint pain, mouth ulcers, those types of things. And then for lab features, both tend to have elevated inflammatory markers, But in left-sided ulcerative colitis or proctitis, so inflammation just limited to the rectum, they tend not to cause as much systemic inflammation. Let's shift our focus to the global prevalence of IBD. This is showing the prevalence of adult and pediatric IBD, a couple years old. You can see that IBD in general is more prevalent in the so-called developed parts of the world that are highlighted in red and orange. And then when we look at the trends of IBD prevalence over time throughout the world, so this is since the 90s, and then detailing different regions of the country, of the world here, excuse me. Essentially, the prevalence is increasing everywhere throughout the globe, but the slice here that we see increasing most dramatically is in East Asia. Thinking about the burden of pediatric IBD specifically, the prevalence and incidence is rising. A quarter of all patients with IBD are diagnosed as pediatric patients in the US, with about 4% of those who are diagnosed before age 5, so very early onset inflammatory bowel disease. And then here's the prevalence and incidence rates in the US in particular, but the disease is rising globally. So let's take a look at our IBD demographics at our own institution. We care for about 1,000 pediatric patients with IBD. You can see that the bulk of the patients are in their teens. This age 20 to 22 group is lower simply because they're aging out and transferring care. It's not that they're being cured, unfortunately. There is a slight male predominance at our institution, and then for race and ethnicity data, most of our patients are white and non-Hispanic. So let's talk about what we know about what causes inflammatory bowel disease. IBD pathogenesis is complex and multifactorial. It involves a combination of genetic predisposition, environmental or personal factors, a disruption in the microbiome, and some sort of immune dysregulation. Honing in on genetic factors specifically, IBD is rarely monogenic, so meaning that there's one a gene involved. That's the full explanation for it, except in certain types of very early onset inflammatory bowel disease, like FOXP3 deficiency or XIAP. And when we look at twin studies, the monozygotic twin concordance rates for Crohn's disease is about 50%. So if one identical twin has Crohn's, the other identical twin has about a 50% chance of also developing Crohn's. And those numbers are even less for ulcerative colitis. So there's definitely more at play than just genetics here. This is underscored when we look back at that map, looking at the global trends in IBD. So if a child born in a country where the IBD prevalence is low, say India, immigrates as a child to a country where the IBD prevalence is high, say the US, their lifetime risk of IBD will match that of someone born in the US. So again, definitely more than just genetics here. So let's talk about those environmental or personal risk factors that might be at play. These exposures occur throughout gestation, birth, and childhood. Prenatally, a maternal diet high in fats and maternal smoking exposure increases the risk of IBD in the child. The mode of birth affects IBD risk as well. So individuals born via C-section delivery have a higher risk of developing inflammatory bowel disease. And then focusing on postnatal risks, highlighting those in childhood here since we're pediatricians, we know that breastfeeding is a protective factor against IBD, while early and frequent antibiotic exposure raises the risk of IBD. And then diet is another really important factor too. So what we call a Western diet, high in fats, sugars, processed foods, increases the risk of IBD. And then also we're discovering that certain food additives or dietary emulsifiers increase the risk of IBD as well. Now, many of these environmental factors affect the microbiome. So this is likely how they are modulating an individual's risk of IBD. We know that in IBD, there are changes in what bacteria types are there and how they function. The details of this are really beyond the scope of this talk, so I won't get into this today. And all of these risk factors accumulate in an immune dysregulation cascade that leads to tissue damage. So there is some thought that certain infections can trigger this dysregulation in the right or wrong circumstances, but IBD is not always preceded by an obvious infection. So we've covered the pathogenesis of IBD. Now let's shift gears and touch on what we know about IBD treatment. So we are really practicing medicine at an incredible time, what I like to call the biologic era, which has now also expanded to include targeted small molecule inhibitors. I'm sure many people in the audience can personally speak to how these new medications have dramatically improved our care for patients in many areas of medicine. So not only in GI, but rheumatology, dermatology, pulmonology, the list goes on. For those of you who don't encounter these types of medications on a daily basis, biologic drugs are large, complex proteins made from living cells that target and neutralize specific molecules on the surface of cells. Small molecule inhibitors are chemically synthesized. They're small, so aptly named, and they block intracellular signaling pathways. So before biologics became available, my GI predecessors relied on steroids, immunomodulators like azathioprine and methotrexate, and mesalamines, or 5-aminosalicylic acids, which are basically topical aspirins that act on the lining of the gut. These were the mainstay of IBD treatment, and we didn't do very well, honestly. Then in the 90s, Remicade or infliximab came out. This targets and neutralizes tumor necrosis factor alpha, a major component in the immune response that's aberrant in IBD. And then later, adalimumab or Humira came out, which is also an anti-TNF. The main difference is that Remicade is an IV infusion, while Humira is an injectable pen that can be given at home. So these dramatically improve the care of our patients with IBD. And even today, these are the foundation of our care for our patients with IBD. And there have been multiple biologics since then, like Entyvio or vedolizumab. This targets integrins so that the lymphocytes are unable to migrate into the intestines and cause further damage. And then Stelara or ustekinumab came out in 2016. This is an anti-cytokine. It targets IL-12 and 23. Next came the small molecule inhibitors. So this is tofacitinib or Xeljanz. This was the first one approved for inflammatory bowel disease. This targets the intracellular JAK-STAT pathway, which is involved in a lot of the inflammation cascade in IBD and many other autoimmune diseases. Then Zeposia or ozanimod, that targets sphingosine 1. So it prevents lymphocyte egress from lymph nodes, kind of a similar concept to the anti-integrin Entyvio. Then Skyrizi, y'all have probably seen commercials for this. I feel like they're pushing this one hard. This is really interesting. It's a more selective IL-23 inhibitor, so similar mechanism of action to Stelara, but it targets a different subunit, so it's really selective for IL-23, and the data look really promising for it. Then Rinvoq, cousin to Xeljanz, upadacitinib, another JAK inhibitor, but again, more selective. So we're getting better at forming these biologics and small molecules that are more selective and seem to have better outcomes. And there's even more to come. There will not be a quiz on this. Do not worry. This is for me and my colleagues to focus on. Just want you all to be aware of the incredible advances over the last few decades in our care for patients with IBD and other autoimmune diseases. So our IBD care now fully revolves around biologics and small molecule inhibitors. The point of this very busy slide is not to go through these treatment recommendation pathways in detail, but simply to highlight all of the medications that are listed here, except for 5-ASAs or mesalamines, are biologics or small molecule inhibitors. So our foundation of our current IBD care revolves around biologics and small molecule inhibitors. So now that we've covered medications in IBD, let's take a moment to establish what our goals of care are for our patients with IBD. So we define remission in 4 main modalities. Clinical remission means being symptom-free, normal growth, normal bone density, and normal psychosocial status. Biochemical remission involves having normal labs and stool markers of inflammation, while endoscopic remission means going from this on scope at diagnosis to this at follow-up. Histologic remission takes that a bit of a step further, going from this on biopsies from the intestine at diagnosis to this at follow-up. And somewhere along this spectrum of endoscopic and histologic remission, we call mucosal healing. We know that mucosal healing is associated with better outcomes, less risk of disease progression, less risk of surgery, lower morbidity and mortality. So this has really shifted to become our main treatment target in IBD. And to assess for each of these, we perform regular clinic visits, regular lab, and a little less frequent stool checks, much more frequently at diagnosis, but then we monitor our patients really at least every 6 months, even when they're doing very well. And then to assess for mucosal healing, it has now become our standard of practice to do a repeat or restaging scope around 4 to 12 months after diagnosis. The time interval, there's no clear consensus on that. Every provider has their own preference, but somewhere between around 4 to 12 months after being on stable, effective therapy to prove that it's really working to achieve mucosal healing. Again, this is our target, mucosal healing. We know how important that is. How good are we at accomplishing this? So let's look at our first goal, clinical remission. These data are from a national IBD cohort with Seattle Children's listed here in blue. When you look at achieving clinical remission, we're doing pretty well, 84%. And Seattle Children's in particular is doing quite well when compared with other institutions around the country. So kudos to us. But when you look at sustained clinical remission rates, we're not doing as well. So this means maintaining clinical remission for a period of 200 days. Not doing as hot on that count. In fact, any maintenance treatment in pediatric inflammatory bowel disease has a 50% failure rate over 2 to 3 years. So we have some progress to make when it comes to achieving sustained clinical remission in our patients. And when we look at mucosal healing rates, we're doing even worse. The numbers vary widely in the literature. This is a really busy table. We're just trying to look at the column on your far right. The numbers aren't great overall. They vary a lot. The definitions of what people determine as mucosal healing, when we assess for that, vary a lot. So you're going to see a lot of variability. Again, this is adult data too. The pediatric data are more limited, but the numbers range from 30 to 50% who achieve mucosal healing in the literature. It's not great. And in general, Crohn's disease has a lower rate of achieving deep mucosal healing than ulcerative colitis. So clearly there's a gap in our ability to provide optimal care and deliver optimal IBD outcomes for our patients with inflammatory bowel disease. So there's some piece of the puzzle that we're missing when we think about IBD and think about how we treat IBD. And I'd like to talk to you about how the intestinal extracellular matrix might serve as this crucial missing link to help us bridge this gap in care. So we've discussed the reliance that we as IBD providers have on biologics and small molecules. This is a nice depiction of how and where these medications work in the intestines. This is a few years old, so some of them are like unnamed. This is now Skyrizi, or risankizumab. But again, showing where in the intestines these medications work and what they target. They are all focused on altering the aberrant immune system, so they are all immunosuppressive. I'd like to shift our attention to what's going on underneath and in between this mucosal immune response in IBD and highlight the extracellular matrix in the intestines. So I'm going to be talking specifically about the intestinal interstitial extracellular matrix. This is a dynamic, complex structure composed of various proteins and glycosaminoglycans. It's found in the lamina propria in the intestines. So again, where the immune cells are residing and fibroblasts as well. It provides structure, strength, and support, but it's not just a physical structural element. The extracellular matrix interacts with integrins, growth factors, cytokines, and inflammatory cells. So as such, the intestinal extracellular matrix has the potential to affect intestinal homeostasis and mucosal immune responses. So I'm going to highlight one specific component of the extracellular matrix, these chondroitin sulfate glycosaminoglycans, or CSGAGs. Here they are in the intestines, again in the lamina propria, residing next to fibroblast and immune cells. These are glycans, or sugar chains, attached to a protein core that consist of repeating change of disaccharide isomers. These are the building block units that repeat. And each isomer is defined by their unique sulfation pattern. Each isomer has its own associated properties, which you can see listed here. So what we call CS, again, chondroitin sulfate O isomer, has no sulfate group. It's more involved in diffusion. These two are more involved in matrix stability. This is DS, or dermatan sulfate. It has 2 sulfate groups at these positions. And then CSA has 1 sulfate group here, also involved in matrix stability. CSC and E are more inflammatory, and there's the sulfate groups there. So again, there's 5 isomers that we find in the intestines total. They each are defined by their unique sulfation pattern, and they each have a unique function associated with them. So the relative abundance of each isomer can affect the properties of the extracellular matrix. Let's connect CS gags and CS isomers to IBD pathogenesis and physiology. In IBD, there's a compromised physical intestinal barrier, an altered pro-invasive microbiome, and immune cell influx and activation. And again, here are where the CS gags are in the intestines. We know that they are active participants in both normal and abnormal intestinal physiology. So the hypothesis that drives most of my research involves pro-inflammatory changes of the intestinal CS gags as a part of IBD pathogenesis. So to begin to investigate this hypothesis, I first had to develop a method to characterize what the CS gag and CS isomer composition is in the human intestine. This hadn't been done before. So with the help of one of my collaborators and mentors, Dr. Kimberly Alonji, who's a matrix biologist at UW, and the UW Mass Spectrometry Center, I developed a method to determine the CS isomer sulfation pattern in the intestines. So in GI, we're really fortunate to have access to lots of intestinal samples taken from biopsies at colonoscopy or endoscopy. So I was able to take formalin-fixed, paraffin-embedded, or FFPE tissue mounted on a slide. Remember that these biopsies have CS gags in them in the lamina propria. So our biopsies are relatively superficial. We don't go super deep. We take them with small little biopsy forceps at the time of scope, but we're able to capture the lamina propria quite nicely when we take those biopsies. And then these biopsies, zooming in further, we see, remember, there's these CS isomers, repeating chains of these isomers that are making up these CS gag sugar chains. We then expose these tissues to an enzyme that digests the CS gag chains and releases these individual isomer units. We then take that, run it through a mass spectrometry machine to determine the relative abundance of each CS isomer in the intestinal biopsy samples. Here's another visual representation of what we're looking at. So here's a colon biopsy slide. This is showing the general architecture of the colon, luminal side here, epithelial layer here. Colonic crypts are diving down. Remember, in the small intestine, we get villi and crypts. In the colon, we just have crypts, no villi. And the crypts are lined by goblet cells, which are full of mucus and don't stain well. So those are kind of the more black areas in this biopsy slide. The blue stain for DAPI is showing cell bodies. It's a nuclear stain. The green stain, CD45, is staining for immune cells or inflammatory cells. And then the red stain is showing where the CS gag chains were present. So it binds to a remnant that's exposed after digestion with the enzyme that we use for this process. So it not only localizes where these CS gags were located in the intestine, it also confirms that our digestion was indeed successful. So when you zoom in, you can see that the CS gags, again in red here, are surrounding cells throughout the lamina propria and are closely related to immune cells in green. So the first question I wanted to answer was related to colonic inflammatory bowel disease. So I'm talking about ulcerative colitis and Crohn's disease that involves the colon. And the next couple data slides that follow are all going to have a little key at the top here, which clues you into what area of the bowel I'm talking about. I'm going to start with the colon and then move to the small bowel. With the help of my colleagues, Dr. Zhang and Dr. Suskind, and our wonderful research coordinators, I got tissues from 56 pediatric patients with colonic IBD taken at diagnosis, so when they had active disease, and compared them to 23 patients who were controls who did not have IBD. This is a combination of true healthy endoscopy subjects who were paid to undergo endoscopy. So they had zero symptoms. That's why their age includes a bit of older population here, since they were 18 and over to give consent to this. And then I also compared that to a group of patients with what we call functional GI disease. So they were seen in GI clinic. They had some sort of symptomatology that prompted the referral and prompted us to order a scope, say diarrhea, abdominal pain. But there was no histologic or endoscopic findings at during their procedure. So they had completely normal findings, but some degree of symptomatology. When I compared those patients to true healthy controls, there were no differences. So for these purposes, I'm lumping them together so we can get some better numbers. So here are their CS chondroitin sulfate isomer profiles. Keep in mind that each isomer here is listed as a percentage of the total CS-GAG content. That's just with the method that we use, we get a percentage of the total. Because each biopsy has a slightly different area, so we're not able to as well quantify the total abundance. So we're looking at relative abundance here. And this key breaks down the general function of each isomer. CSA in blue is by far the most abundant. And in controls or IBD at diagnosis compared to controls, is significantly decreased. Again, this is a stabilizing isomer. It's decreased in active IBD. The other stabilizing isomer, dermatan sulfate, is at the top, much smaller piece of that pie, but it's also decreased. Diffusion isomer CSO, not significantly changed. The two inflammatory isomers, CSC and CSE, in yellow and red here, are significantly increased in active IBD. So there are pathologic changes in the CS isomer composition in active colonic IBD in a manner that we would predict, that makes sense with the disease physiology. The inflammatory isomers are increased, the stabilizing isomers are decreased. Next, I wanted to see how the CS isomer composition might change in IBD that's being treated and is effectively in remission. This will help me know if the changes that I saw in active IBD are some underlying predisposition to the disease, or whether they're involved or at least modulated by the underlying disease process. So this is the same data as on the previous slide, but then I'm adding a third cohort to our analysis of patients with colonic IBD that's in clinical remission. Remember, we had many ways of defining remission. This one is clinical remission, and most of these patients are on anti-tumor necrosis factor alpha biologic agents at follow-up. You can see that in patients with IBD in clinical remission at follow-up, the stabilizing isomers increase and the inflammatory isomers decrease. And when you compare them to controls, there's no difference. So they essentially go back to match controls. So the CS-GAG changes seen in active IBD are not just a predisposition to the disease. They're actively being modulated by the disease activity, and they may be involved in disease pathogenesis. And if this is true, they could represent a novel treatment target or even a biomarker or clinical predictor tool. So if this were the case, I hypothesize that these CS-GAG findings might correlate with disease activity. Which leads me to my next analysis, where I correlated the CS isomer abundance with clinical disease activity scores first. I found that stabilizing isomers correlate inversely with clinical disease activity. So these are scores ranging from 0 to 80 that we use to assess pediatric ulcerative colitis activity and pediatric Crohn's disease activity. Works well for colonic disease because remember, colonic disease, more distal, produces a lot more symptoms. So when you ask a patient how often they're going to the bathroom, they're waking up at night to going to the bathroom, how much pain they're having, how many stools a day, how much blood in the stools, it gives a pretty good depiction of how severe their disease is. So again, CSA stabilizing isomer, so the higher the CSA content, the lower the disease activity scores. Conversely, the lower content of CSA, the stabilizing isomer, associated with more severe clinical disease. Same is true for the inflammatory isomer. I'm showing CSC here. Higher amounts of this inflammatory isomer are associated with higher disease activity scores. Then I looked at histologic inflammation. So we don't get nice range of scores from 0 to 80 on the histologic inflammation. It's just really grouped as no inflammation, mild, moderate, or severe. So I'm showing the associations here of the CSA content with those categories that the pathologist used on their report looking at the slides. You can see for the stabilizing CSA isomer, there's a stepwise decrease with increasing histologic inflammation. And then when we look at the inflammatory isomer, I'm showing CSE here as a nice representation. There's a stepwise increase with increasing histologic severity. So CS isomers correlate with IBD disease severity measured both clinically and histologically in colonic IBD in a manner predictive of being intricately involved in the disease pathogenesis and progression. So far, I've focused on colonic IBD. So I wanted next to shift gears and look at IBD involving the small bowel, namely ileal Crohn's disease. You can see that in active IBD, active ileal IBD, so Crohn's disease at diagnosis, compared to the same controls, but we're looking at their ileum, not their colon now, there's an increase in inflammatory isomers. So CSE is going up, CSC doesn't quite reach significance, CSA goes down to reach significance, dermatan sulfate trends down but doesn't quite reach significance. Both of these changes are reversed at follow-up to match controls. And again, most of these patients were also on anti-TNF biologic agents at follow-up. So overall, we see a similar pattern to colonic IBD, where stabilizing isomers decrease and inflammatory isomers increase in active ileal Crohn's, and this is mostly reversed at follow-up on effective therapy. Then when I looked at correlation with disease activity for ileal Crohn's disease, I couldn't necessarily do the disease activity scores as well, because remember, ileal Crohn's disease, it affects the small bowel. The symptoms can be a little more vague, that they're not as easily quantified and scored as colonic Crohn's disease or ulcerative colitis. So I'm just showing you the histology data here. But when we look at the stabilizing CSA isomer, it decreases in a stepwise fashion associated with increasing histologic inflammation. And the opposite is true for inflammatory CSE, stepwise increase with increasing histologic inflammation. So overall, this suggests that the CS isomer abundance is directly related to tissue inflammation. So hit you with a lot of data. I know that you're not all into research and numbers like I am. So let's take a moment to recap and summarize. So in colonic and ileal IBD, stabilizing chondroitin sulfate isomers are decreased, and these correlate inversely with disease activity, where inflammatory isomers are increased, correlating directly with disease activity. These changes are reversed at follow-up on effective therapy. So taken together, these suggest that pathologic CS-GAG alterations seem to be intricately involved in IBD pathogenesis and activity. So when we look back at if you're like me, you like visual representations of things. I think all gastroenterologists are visual people who like to see things visually. So let's go back to our model of the changes that we see in the intestine in IBD. So we've confirmed that we do indeed see pathologic CS-GAG alterations in active IBD that are modulated by disease activity and not just a predisposition to the disease. However, whether this is a cause of the disease or some secondary effect of these other processes remains to be determined. If indeed pathologic CS-GAG alterations are really involved in IBD pathogenesis, they should represent a novel therapeutic target, which is really enticing since targeting this CS-GAG composition would not lead to systemic immunosuppression, which, as I discussed earlier, the vast majority of our treatments do. So building off this human data, I then employed murine or mouse preclinical models of IBD to test whether augmenting stabilizing CS isomers can improve IBD outcomes. So really taking this from bedside to bench and then hopefully back to the bedside. So I took 2 groups of mice and gave them DSS, dextran sodium sulfate. This is a chemical colytic agent that causes intestinal injury that mimics inflammatory bowel disease, mostly colonic disease that mimics ulcerative colitis. So both of these mice got 2% DSS for 7 days. This is a well-developed protocol to produce ulcerative colitis-like phenotype in mice. One group of these mice were also concurrently given oral dermatan sulfate. This gets a little confusing because we've got DSS and DS. So I have a little key here. And then vehicle, VEH, just means that they got regular drinking waters. After 7 days, mice were sacked, tissues were collected, these following measures, so clinical disease scoring, histologic damage assessment, and then I also determined the CS-GAG content in their colonic biopsies using the same method that I detailed earlier, so thankfully our method works for humans and mice. When we look at the group that got the stabilizing stabilizing dermatan sulfate isomer, their clinical disease scores were lower, so an improvement in clinical disease outcomes. When we look at their histologic damage, lower scores, so improved pathologic outcomes as well. And when we look at what that histologic damage, how that correlates to the percentage of dermatan sulfate in the colon, there's this nice relationship. So the more that we were able to increase the dermatan sulfate in their colons, the less severe disease activity they had. So these preclinical results suggest that CS GAGs are involved in IBD pathogenesis and that targeting these CS isomers could serve as a novel approach to treat IBD. So I'm building off these initial studies now. So I hope that you have come away from this knowing a few things that will help us all get towards a common goal of better IBD care. So in this roadmap of how we can move to more optimal IBD care, the first two milestones really fall on the general pediatrician to address. So to help mitigate the risk of IBD, it's important for us all to recognize that the burden of IBD is increasing. Globally, nationally, adult IBD, pediatric IBD, it's increasing. I hope I've convinced you of this today. To help mitigate the risk of IBD, it's important for the general pediatrician to know what risk factors there are for IBD, and a lot of these really come at the level of the general pediatrician, and there's not as much that we as gastroenterologists can do about it, so I want to highlight a few of these things. We know that, again, early and frequent antibiotic exposure and use in childhood increases the risk of IBD, so just highlighting the importance of good antibiotic stewardship. Breastfeeding, again, lowers your risk of IBD, so doing all we can to promote breastfeeding practices. And then we know that diet's a big part of IBD pathogenesis as well, so doing all we can to help promote healthy eating, minimizing processed foods, as well as potentially at the legislative level of improving what's in the foods that we're eating. And then for increased recognition, reminding ourselves that IBD presentation really depends on the involved bowel. So one of the things that me and my colleagues see the most in terms of a delayed diagnosis, so delayed presentation to us as specialists, is our patients with small bowel Crohn's disease, who I've discussed a few times. They don't have as overt symptoms. They're not running to the bathroom multiple times a day, having bloody diarrhea and urgency. They might have some mild abdominal pain, even constipation, but when you look at their growth charts, they're not growing. When you actually draw some labs, their inflammatory markers are sky high. So dig a little bit deeper, knowing that IBD doesn't always present with diarrhea and bloody diarrhea. So the next milestones to improve our understanding of IBD pathogenesis and discover novel therapies fall on myself and my colleagues as IBD practitioners and researchers. So this is not as much a call to action, but more of summary that I hope you learned from this talk. So despite our latest generation of new biologics, new small molecule inhibitors, we still fall short of our mucosal healing goals for our patients, which we know is really our treatment target goal that's associated with better outcomes. The intestinal extracellular matrix is being increasingly recognized in IBD pathogenesis. My work has shown that CS GAGs and the CS isomers are dramatically altered in IBD in a way that correlates with disease activity. And I'm now testing CS GAG modulation as a novel therapeutic approach in IBD in preclinical models. So I'd like to thank my mentors, my lab members, our IBD center, the UW Mass Spec Center, and then my grant funding from these sources. And thank you all for listening to me today, and I would love to take any questions.
Hi, Kendra. Good job. So my question is about the way that you were treating at the bench side, like for the treatment of with the dermatan sulfate. Do you think that that was absorbed through the stomach and then systemically delivered, or do you think it's a topical approach? And then is there anything kind of commercially available currently that that you would then consider using in a trial?
Yeah, fantastic questions. So I've given dermatan sulfate and then chondroitin sulfate A orally to mice. I didn't show those data just because I didn't have time, but the data also look really promising too. I give it just mixed into their drinking water, and I do see an increase in the content of that isomer in their colon. So I do feel like some of it is truly being absorbed. I think it's a local effect, not a systemic effect, because again, this Nice thing about dealing with GI is the medications do come in very close contact to the areas that we're trying to target. And there's been certain studies that the chondroitin sulfates are not broken down or digested by the small intestine. So in theory, they should be reaching the colon intact. What I have not done is some sort of like radio tracer study to figure out where these are actually going. That's my next goal. But I'm not trained in how to do that yet. So I need some collaboration and training to do that. But that's where I want to go next, is really hone in the mechanism. How is this affecting disease outcomes? And then I didn't mention this, but remember in IBD pathogenesis, the microbiome disruption is so key. And we do know that certain species, so we don't have the right enzymes to break down and modulate glycosaminoglycans as much, but the bacteria in the colon do. So they could be modulating this interaction as well. For human data, they have not looked at CS isomers specifically. This is really novel that I've actually broken down what isomers are present in the intestines and at what levels. But there have been population studies looking at adults with IBD who also happen to be on oral chondroitin sulfate joint supplements for osteoarthritis, and they tend to have better IBD outcomes. So they're not looking at each individual isomer specifically, but just the commercially available over-the-counter joint supplements that you can get seem to maybe have an improvement in IBD outcomes. Which is actually really nice if I'm looking to translate these preclinical studies to clinical trials. It's already mostly FDA approved. But I can synthesize as well as purchase the isomers specifically, not just the overall chondroitin sulfate joint supplements. So when I'm testing these in the lab, I'm really testing the exact isomer.
It's fantastic work, Kendra. Congratulations. Really impressive research and so well presented. And I really appreciate your call out for the general pediatricians among us who are thinking about what are we doing for prevention. And I just had follow-up questions about the call out on breastfeeding and processed foods. And I was hoping you could share, if you know from the literature, is there a particular dose of breastfeeding? I know we have a lot of discussion about what's the duration that we need to try to target for feeding. And then any particular thoughts on if we're going to go after some of the processed foods, because it's impossible to eliminate them. Are there particular areas that you would suggest?
Yeah, great questions. So first, to tackle the subject of breastfeeding, I wish someone were studying this and really honed in on like what the amount of how much of the content, 50% breast milk, 50% formula, for what duration. There's so many variables there. We don't have the data to make a call on that. I think in general, any degree of breastfeeding is better than none, and the longer you can do it, the better. Really interesting to my research in particular is that when they analyze certain components of breast milk, they're looking at it more in decreasing necrotizing enterocolitis in preterm infants, because we know that breast milk is important in that. There are glycosaminoglycans present in breast milk. So really interesting tie-in to my research. Next, looking at the diet and processed foods, it's such a complex issue. My goodness, like from social, economic factors, political factors, it's really hard to be able to draw exact conclusions. And I do think that the diet is really tied in with the microbiome shifts. Because we know that there's other research looking at giving short chain fatty acids, so basically the breakdown products of what our good bacteria are making with fiber and healthy things in the diet. When we give those to mice with IBD, that produces better outcomes. So we know the microbiome is important. For big targets, I think limiting processed food, the ultra processed foods, because we know that the food emulsifiers and food additives, food dyes, things like that, all have worse outcomes for IBD. So in general, do you focus on what to take away or do you focus on what to build in? I think focusing on whole foods, healthy diet, fruits, vegetables, well-rounded meal is personally what I do personally for my family and talk to my patients about more of like, what do we focus on instead of what do we take away?
Yeah, thank you. Just a comment and then a question. I appreciated your, I think the statement was why I find GI fun. And that's going to be a good antidote to burnout over time for all of us. And don't touch my cinnamon rolls. That was the other. But the question I had, you mentioned there was a huge variability in the follow-up. Is there any guidance on that? Because these are sedated procedures and resource intensive and expensive. So any standardization seems it would be very, very helpful for both cost containment or most importantly, quality assessment.
Yeah, fantastic question. So it used to not really be our standard of care, a couple of decades ago that we would do restaging scopes. But as the data came out that focusing on targeting really mucosal healing led to so much better outcomes, in order to assess for mucosal healing, you need to do a repeat scope. So there are, a shift in the national and international guidelines that involve a restaging scope. The timeline of when exactly that happens does vary. There's a window of, you want it to be long enough that the therapies had time to work, right? You don't want to catch it too soon, because if you see some degree of inflammation, you don't know if that's just, the therapy hasn't had quite enough time to work, or if it's not working at all. But you don't want it so long that you're having your patient suffer through, a year plus of suboptimally controlled disease. So I'd say most commonly around the country, probably 6 to 12 months. We've had some providers and a little bit more shift to try to do things a little bit earlier. And I will say personally, the severity of the disease and type of disease for my patients does dictate the timeline that I personally will use. Someone who's had small bowel Crohn's with really deep ulcers, I think they have a higher risk of progressing to needing a bowel resection. I'll scope much earlier, and they're in growth failure, things like that, than someone with more mild to moderate ulcerative colitis, again, whose symptoms probably are going to clue me into how their disease activity is going on better than someone with isolated small bowel disease.
Thanks. I have a question from our online team. Kelly Fawcett asks, do you know of any pathologic and therapeutic correlation to another disease, GVHD? Graft versus.
Great question. I do not, but my next step is, so I want to build off the preclinical studies and hone in on mechanisms. And then I also want to look at other disease types of colonic inflammation to see if these changes that I'm seeing in IBD are specific to IBD or if they're found in any sort of colonic inflammation. So my next goal is to pull tissues from patients with GVHD, with eosinophilic colitis, lymphocytic colitis, Hirschsprung's associated enterocolitis, and see if these changes that I'm finding are specific to IBD or not. So I don't have answers yet, but hopefully I will have some answers moving forward.
All right, this has been a fabulous presentation. I'm so impressed by all of your work and research, and thank you so much for giving us your time this morning, and thank you everybody for being here. We really appreciate you, and we'll see you next week. Thanks. Let's give her one more hand.